Good morning or good afternoon, everyone, depending on what part of the country you're joining us from. I want to welcome everybody. My name is Waldo Michaels Carrasco. I'm the Director for Health Information for the Center for Health Information Sharing and Innovation at the Illinois Public Health Institute, and also the Co-Director of Data Across Sectors for Health. We are just going to give folks a couple of one more minute to finish joining the room, and then we'll get started here. All right. Well, as I said, my name is Waldo Michaels Carrasco. I'm the co-director of Data Across Sectors for Health. And we want to welcome everyone to our third installment in our three-part webinar series, Advancing Community Health Through Equitable Data Ecosystems. And this is being offered by Data Across Sectors for Health. Our program office is co-led by the Illinois Public Health Institute and the Michigan Public Health Institute, and funded by the Robert Wood Johnson Foundation. This webinar introduces the DASH conceptual framework, which highlights some key domains of shared multi-sector data landscapes and helps us guide communities to leverage their data ecosystems for equitable systems change. In the spirit of the all teach, all learn process, we highlight lessons learned by and from our awardees that we found illuminating and hope can light up other projects to further discussion on the critical considerations regarding data and equity. So some tips for Zoom for today's session. American Sign Language interpretation is available, so please have your screen view set to speaker view to view the speakers and interpreters. Use the chat. We don't have chat on today's system, but you can use the QA throughout the session, the presentations, to submit your questions. And we'll have a Q&A session at the end where we'll refer back to those. If you do have technical issues, go ahead and use the QA as well to ask for assistance there. Closed captioning, you can hide your subtitles in your control panel if you do not wish to access the closed captioning. And we will have the hand raising feature during the QA section, and you can come off your mic at that point to ask your questions if you prefer. So again, the session is being presented by Data Across Sectors for Health, or DASH, and we are funded by the Robert Wood Johnson Institute and collaboratively run out of the Illinois Public Health Institute and the Michigan Public Health Institute. So our equitable data ecosystem for advancing community health is derived through awardee insights, our national inventory survey, and the all-in network and thought partners. DASH has identified key factors which are important for sharing and using data across sectors with communities to support more equitable systems that create the conditions for health and well-being. In this latest version of the DASH framework, we dive deeper into how equity as a process and outcome intersects with data ecosystems and data infrastructure that is built to unlock the power of data ecosystems towards social good. The framework also includes fundamental components and intersections of data sharing, such as factors that support strong data sharing foundations and recommended components of data ecosystems that facilitate equitable data sharing. The factors we've identified relate to building foundation with community, sharing community data ecosystems, the role of policy in multi-sector approach, and equitable systems change. By connecting information systems and sharing data across sectors, particularly in ways that are community-driven and accountable to community members, and meaningful, sustainable, and equitable community health improvements are possible. Our first session, which you can access through a recording on -connect.org, focused on building foundations with community. Panelists from funded communities discussed the challenges and complexities involved in relationship building and opportunities for establishing relationships among partners within the community. The second webinar in the series, Developing Shared Community Data Ecosystems, is also available at -connect.org. Today, we're going to talk about the policy and market forces component of the framework. So we know that communities engaging in data sharing have to navigate complex and at times competing external forces. In this moment, where there is an unparalleled federal funding being made available, policymakers are searching for system strategies that can drive equitable community health improvement. When we at DASH say policy in this context, we are focusing on policy related to state and federal activities that affect local data sharing efforts and that are part of local community and the part that local communities can play in creating a more effective policy sphere. In a similar way, market forces for us refers to the social, ideological, political, economic, and workforce trends that pull and push a community's efforts at collaboration within their particular ecosystem. So for today's presentations and webinar and discussion, our session goals are to describe the role of market forces and policies in shaping capacities, opportunities, and barriers to data sharing within data ecosystems. To identify the role of communities play in creating a more effective and just policy sphere. And third, to understand the available data within a capitalist system that often reflects inequities that shape our society. For today's discussion, and to provide a real world lived experience of how we developed this aspect of the framework, our third session will highlight DASH funded communities' insights on navigating market forces and policies. Our panelists from DASH funded communities are here with us to share these insights and lessons as they work to realize those foundational elements of data ecosystems that promote health, equity, and ultimately community thriving. We'll start off hearing from Greg Bloom, and then we'll hear from David Palms. Greg?
Thank you, Waldo. You can hear me?
We can.
Right on. Okay, so I've shared a few links in the chat. I'm going to walk through a talk that I've actually given in quite a few contexts involving DASH. So if folks might have seen this talk in all-in conferences or maybe participated in our affinity group, some of this is going to sound familiar, but then we'll hear from David Palms, my collaborator at the DCPCA in the District of Columbia, about how they're putting some of these ideas into practice. And before I start, I'll just share again that we're going to be talking about a very specific kind of data in a very specific context of market failure and the strategies that we've taken to cope with this kind of data. Data writ large obviously involves all kinds of other considerations that we won't directly address, but I encourage you to think about this as an example of patterns that also apply in other related information domains, and we can think about how some of the approaches that we've used in this domain might be relevant elsewhere as well. So with that said, I'm going to share my screen and jump right in. So again, by introduction, my name is Greg Bloom. I lead the Open Referral Initiative, and I'm trying to, here we go, slideshow. So Open Referral is a community of practice dedicated to the establishment of resource directory information as a public good. Here's some information about us. You can also follow up on the links I shared in the chat, and you can check out the resources that we will share after the event to see more about our work. So personally, I actually I learned about this problem, the resource directory information problem, personally while working at an organization in the District of Columbia in partnership with the DCPCA well over 10 years ago. And Bread for the City, the organization where I worked, has the largest food pantry in the city, but also has a medical clinic and a legal clinic and social workers. They have multiple locations, various services provided in different combinations across those locations. And on top of everything else, the social workers maintained a database of the resources that they would refer people to outside of our doors, because we didn't do everything. And our social workers maintained that information in a Microsoft Access database on Friday afternoons. But they did a good enough job that word got out, and eventually a significant amount of their time was spent helping people figure out where else to go, because people would come to us to get referrals elsewhere. And this is how I found out about the resource directory information problem. Over the course of about 5 years, I watched multiple other organizations try to take our Access database and deploy a website that would become like the one-stop shop of community resources. There were many entrepreneurs interested in leveraging this information to develop good products that could solve these problems. And over the course of about 5 years, I watched all of these projects fail. And in the course of learning about that failure, I reluctantly learned about this domain and its details and why it's so slippery. So to reiterate, so we're on the same page, we're just talking here about directory information about public services offered to people in need. Which agencies provide those services, what services are available, where are they located, how can you access them? So that's what we mean by this kind of data. And this is actually deceptively difficult. Many people don't realize how complex this information is, especially if your point of reference is something like Yelp. You might imagine that just like find me a food pantry is a pretty easy proposition, but the challenge is actually that organizations might provide multiple different kinds of services in different combinations at different locations. There might be varying requirements as to who's eligible for those services. They might describe those services using different words in front of different audiences. And there's no one institution that has any authority over all of the different domains of health, human, and social services. So there isn't necessarily one place where this information can all be collected. And on top of that, it's changing all the time as funding changes, as staff comes and goes. And most importantly, especially since, and this isn't on this slide, but especially since we're here to talk about markets and market failure, it's important to understand the root cause of the slipperiness of this problem is that organizations that provide services to people who don't pay them for those services don't have strong incentives to be found by more people. So essentially, the sectors of human services don't really operate like a normal market would, in which you have incentives to promote your information so that people find your information so that they can find you. Not saying that organizations hide, although sometimes that does actually happen. It's just not actually a priority for them to do outreach to get more users. This is speaking really broadly, but even when organizations do have strong incentives to get more people coming to them, then they end up saying, oh, well, we provide services A through Z, when really they just redirect people back out the door. Which means if you want reliable information, about these services, you have to make phone calls. I mean, you have to know what questions to ask. So the work of maintaining information about the services available to people in need, that actually has become in and of itself a market of information intermediaries. This market has a whole range of conventional providers of information and referral services known as INR, such as 211s and aging and disability resource centers, often represented by the Alliance of Information and Referral Systems, which is the industry association for the market of information and referral providers. And there's a whole class of web-based startup companies like Activate Care and NowPow, which is acquired by Unite Us, and Aunt Bertha, which is now Find Help, companies that sort of come and go every few years, and many of them have websites that they promote to companies where you can also find information about services. But what ends up happening is all of these different players in the market for information about human services end up competing with each other to see who has the best record of these information, this information. So that becomes a situation that I call competitive databasing. And it yields this market failure where many different players are all chasing after the same information. The more requests an organization gets to go and update its information on anybody's website, the less likely it is to actually comply and provide that information. I found that out myself because I was the person who would get these automated emails saying, please spend hours of your day updating our website, and I had no reason to do so. And so what we have here is market failure, where there's more and more sources of less and less reliable information, demand increases and supply increases, but demand is not met. And when I was first learning about this problem and describing it to people, savvy types in Silicon Valley and whatnot would usually tell me what you should do is build the best website, scrape everybody else's data, and win the market, essentially. Solve the problem by being the one that everybody turns to because you're just the best. It didn't take much to see that you can't actually solve this problem through the logic that created the problem in the first place. We need to be able to step back from that notion of sort of problem solving through competition, because it is the competition that is actually creating the problem in a manner of speaking. And so we need to escape from this logic and find new ways of thinking about how to provide information about services available to people in need. So this is our vision that emerged from years of conversation in DC and with stakeholders around the country, which is instead of one system that would solve everybody's problem, we want a healthy information ecosystem in which people can find whatever they're looking for wherever they look for it, right? So that this information, instead of as a commodity available on a market, it ought to be treated as infrastructure that can be used by many different market players. And this is a simplified version of what that might look like given the problem slide that I shared earlier. To be clear, Open Referral did not actually build that infrastructure. I'm improving the slide. I hope to have a new version soon. Open Referral, this is just our vision of infrastructure in any given community that would serve the same information up through many different information channels as an interoperable open data as a public good. The first step we took in that direction is to develop interoperability specifications, which you might call protocols, basically agreements for how data will be structured so that they can be shared among many different information systems, so that it can become frictionless for data to flow from wherever it's being maintained to wherever it might be used. And we developed these specifications in dialogue with stakeholders and market actors, both in the conventional information and referral call center market and the emerging website market, as well as the Alliance of Information and Referral Systems, which in 2018 formally endorsed our specifications as industry standards, meaning the Alliance of Information and Referral Systems credits information and referral providers and their vendors. They offer training and formal guidance, and now use of these data exchange protocols that Open Referral has developed it's expected as a sort of condition of doing business in the field. Actually, as it happens, earlier this year, the United Kingdom, the national government in the United Kingdom also formally adopted these as national standards, and they're in use in Canada by the primary providers of this information. So these are international data standards, which is very exciting. But again, this only solves the first piece of the puzzle that enables all these different actors in a market to quote unquote speak the same machine language, meaning on some level they're all in the same universe of data, and they can all in theory play well together and work alongside each other. Also, as part of this process, members of our community have developed an array of different user-facing tools that connect people to this information in various ways. So there's now an open ecosystem of open source tools that can be freely redeployed, that are much easier to adapt than building a new system from scratch. Again, this makes the market a healthier place, because the simple stuff of building a website, which I want to remind everybody, websites are not hard to build. Useful websites are very hard to build, but it's very easy to build a website. And we've made that easy work sort of a no-brainer. There's a variety of tools that will help people navigate a resource database. What we don't have is the ability to reliably and sustainably produce the information that these tools will serve up. And that is the next challenge that Open Referral sought to tackle. In partnership with communities around the country, we are trying to answer the question: if resource data is public information and therefore should be openly accessible and freely usable by anyone in any context, how can we sustain its maintenance if it goes out of date quickly and somebody has to reliably maintain it, but everybody should be able to access it for free? This is a public good problem. This is known in different economic contexts. Markets will fail to provide public goods because they're the kinds of things that everybody benefits from, but they're very difficult to monetize. And it's very difficult to measure the value and cost out the price of a public good. And so we have to find ways of providing it outside of the market. In fact, that's how many markets are built, is on top of reliably provided public goods that aren't private, but are in fact prearranged collectively. So I'm going to briefly talk about different models of providing infrastructure for resource directory information that can support a market of different actors using the same public information towards different ends. And then we can talk later about how policy can enable us to promote these options and make them easier to implement. So briefly, one mode of providing this information through open data infrastructure we can call the register, and a register is an official list. And with data standards, an official list of information can be accessed by many different information systems concurrently. And we'll talk about a data utility model, which is similar to a power company or a gas company, where there's one designated entity that has a monopoly on the service of providing this critical public utility. And there's some means by which that utility is sustained for a service that everybody uses. And then there's a data collaborative model, or if you're being fancy, the federation, in which you have many different players that are semi-autonomous, but they cooperate together as part of a network. And we're going to look at each of these models briefly and then talk about them more in the context of the BC project. So the model of a service register. In this context, a funder or some other authority institution like an accrediting agency, or in some cases like a food bank that supplies food to many different partners that have pantries, some sort of authority institution can say there will be an official list of all the services provided by any organization that does business with us. An official list is known as a register, and an authority can establish a register by making making it a requirement to be listed in that register and up to date as the cost of doing business. The important thing, I have a little diagram here to explain this concept with a haiku in the top left. Self-updated list, authority requires it, monitored for trust. The important thing about a register is even if an organization is required to update their information in a register is only trustworthy if that requirement is monitored and if there are methods one way or another of compliance. So we believe that a register entails not just like a magical self-updating information system, but a designated data custodian or a steward who's responsible for ensuring that a given set of service providers that have a relationship with a given funder or authority institution are required as a matter of policy to be listed in a register, which then can be accessible to any number of organizations and third-party providers in a market. So this isn't a magic bullet because obviously there's many different funders at many different scales and good luck getting them all to do the same thing at the same time, but it is a tool in our box when thinking about how to solve this problem in a way that works for an entire market. We have some examples of registers. David will talk about one shortly. The New York City Mayor's Office, for another example, now publishes a canonical list of all the organizations that receive contracts from mayoral agencies that provide health and human services. It's official public information. It's not quite a complete resource directory, but it is at least a register of the organizations that receive city contracts. And it can be integrated with other data sets. So the second model I'll talk briefly about is what I call a data utility. And many organizations that have been doing this information intermediary business for years are in a position to evolve into a data utility, such as a 211. And in a data utility, a referral provider that maintains a resource directory makes the data in that directory open for everybody to use. It becomes infrastructure that any number of third-party information systems can reference across a whole market. And the data utility has to become sustainable. So if a government is not simply funding the production of this information, which personally I believe it probably ought to, but in our actual world, that's often something that doesn't happen, then the data utility needs to find some other method of producing information sustainably that everybody can use while charging some organizations for presumably value-adding services and premium features. So we've described this here, where a data utility has a staff of data custodians that collect information about service providers, as you see there on the bottom of the circle. They maintain that information in an open access database. That database is accessible to referral systems and other third parties like websites, like the organizations that are currently competing with each other. They can all potentially access the same data. Some of them are presumably going to want to pay for example, contractual guarantees that the data won't go away for the duration of their contract, or maybe they'll want to pay for curation or reports and analytics, or maybe they could build their own website, but they probably don't want to. Maybe they don't really have the capacity to do it, and the utility can deploy a customized website for them for a fee. So this is a model that we've seen work in other domains. We've seen organizations like 211 provide services like this, but something on an ad hoc basis, and we're encouraging the field to adopt this model as an open infrastructural solution to market failure for resource data. We can talk about that a little bit more in a second. I can talk through some of the tiered value propositions for actual monetization of otherwise openly available information in the discussion afterwards. And the third model that I'll describe here is what I'd call a data collaborative, or if you're being fancy, a federation. And a federation is a system of systems, essentially. There's many different organizations that might maintain resource directory information. That information might overlap, and they develop cooperative arrangements so that they can have different information systems that share the same data, and maybe they divvy up responsibilities and collectively have higher quality information through their cooperation with lower collective cost, because they don't all have to be collecting everything themselves. And so I have a pretty basic diagram here. This is probably when it's worth mentioning that these models that I described to you are not either or. They're great tastes that taste great together. The right answer for any community is probably some combination thereof. Perhaps a utility organization is the primary provider of resource directory information and can be the baseline coordinator of a federation or a collaborative. A utility can deploy and monitor registers for authority institutions like funders and so on and so forth. Basically, what we have to do here is engage in market shaping, thinking through what is the right design for the infrastructure to support any given community's field of referral providers. That's going to vary from place to place, but some basic premises and the core standards can be propagated to make it much easier to develop appropriate arrangements. So we have some examples of this data federation in motion. We had an organization called Benetech that developed a product called ServiceNet, which is still in development, so that many different organizations with many different directories can compare their information and collaborate on its maintenance. Ultimately, these are still problems that we have to solve in motion together with stakeholders. This is an important thing that we've learned, is that markets will fail, but stakeholders can get together and talk to each other about what they actually want in their community, and you can have collective action emerge to set markets up to be more effective through intentional choices that we make together. And I would love to explore the opportunity to design that kind of dialogue and pilot project in a community with you all. And I'll pause here so we can learn more about how the DC Community Resource Information Exchange is taking these ideas and building sustainable infrastructure there. So I'll close with this and turn it over to my colleague, David Palms.
Great. Thank you so much, Greg. Good afternoon, everyone. My name is David Palms. I am the Partnerships Manager at the DC Primary Care Association. I'm going to tell you a little bit about DCPCA and our coalition, DC Pact, and the Community Resource Information and Exchange Initiative, or CORI. And I'll also note, just like Greg, I have my background working in food assistance, emergency and charitable food at the Capital Area Food Bank, which is also what sort of brought me into this space. So the gradual merging of social needs and public health is driving what I think is our approach to the market shaping in this case. So DC Pact, or Positive Accountable Community Transformation, is a collective impact coalition effort. I like to start with our problem, vision, and mission. Racism and the lack of accountability, alignment, and investment has led to inequitable social conditions, health, and well-being outcomes. You might consider that to be something like what Greg just described as a market failure writ large. And so we have been envisioning since 2016 building a seamless, accountable health community that provides care and social conditions for racial and health equity and for community well-being. And we're doing that by building a movement to create that through community leadership, policy change, infrastructure development, and care improvement. And today's piece emphasizes heavily infrastructure development. So DC Pact is based on two models. The accountable health community model is the first one, and some folks might be familiar with that from Center for Medicaid and Medicare Services, which funded a number of sites across the country to implement this, really bridging information and other types of referral information and navigation and provision of even aligned services in testing across the country in a number of different cities, as I mentioned. DC did not receive any accountable health community model funding, but we've continuously looked at and tried to incorporate this model into the way that we have developed our approach. Secondly, as I mentioned, we use collective impact heavily. So collective impact, I think the key thing is that we focus on evolution We focus on areas where we don't know what the solutions and all the resources might be. They need to emerge through process. And so we try to solve problems in front of us towards a set of goals that we've developed for ourselves using the tools and techniques that the collective impact movement has put out over the last several years. So our origin then, as I've mentioned, with the CMS Accountable Health Community Project, we put together a common agenda, a key element of collective impact. We have since then, as I mentioned, continued to work on the accountable health community model. That let us receive funding from DC Medicaid in 2019 to perform the initial community needs assessment. I'll talk a little bit more about that in a moment, as well as the work that we started in 2020, which is the actual technical development phase. And since then, both working on Corey, working on other aspects of our PACT agenda led us to update our common agenda with the language that I shared at the beginning, as well as with the strategic goals that you see at the bottom here. And those goals focus on social risk management, focus on DC PACT acting as a hub for health system action, focus on the technology infrastructure for the activities that we're trying to address, and then finally focus on leveraging well-being assessment to drive new forms of accountability toward progress on social determinants of health. And you can see a list of our members on the left here. So generally speaking, success for DC PACT in any of our efforts looks like building capacity for organizational and system change, building shared measurement consensus, and providing a strong collective framework. So in different ways, we've tried to get around some of the market challenges that Greg has described by acting as a force for collective solutions, shared measurement of what we mean by progress on social determinants, and trying to work through our partners and building on DCPCA's long history as advocates for health equity in the district to really try to provide a leadership in that space. And that's been absolutely reliant on partnerships with a number of key partners, DC Medicaid being one of the foremost. DC Medicaid, or Department of Healthcare Finance, I'll refer to them as DHCF generally, began in 2017, holding a series of discussions, looking at how to use social need data, what does it mean to collect and use it within the Medicaid system. And through a lot of stakeholder engagement, they developed their state Medicaid health IT plan in 2018. There's since been an updated one in 2022. You can see a link in the bottom right there if you're interested in that. But that has really laid out what the needs are for the community and documenting that for for DHCF's ability to draw down CMS funding for a lot of these activities, since HIE and health technology generally is federally supported. So the work that we did with them continued in 2018 and 2019. We formed an action team, a working group with a number of different parties, really coming together to look very closely at the solutions that are out there in the market, to look at what other cities and states have been doing to address some of these challenges and work toward creating more seamless health communities through technology. And so after that, we, in 2019 at DCPCA, led a formal community-wide needs assessment, interviewing a couple dozen district organizations, doing surveys and assessments and focus groups, workflow assessments. This was funded in particular through local funding through the DC Council. And the exciting part about that is, that enabled us to begin pulling down federal matching funds based on the initial local funding. And the federal matching funds came down to support a technical solution that was really solidly engaged in what stakeholders were saying needed to happen with these solutions. And so beginning to address some of these challenges in the market, we said we wanted the systems that were rolled out for organizations in the health and social service sectors to be easy to use, to be compatible with both existing provider EHRs and existing community-based organization workflows, which is one of the harder places for achieving seamless solutions that address these market challenges. And for that reason, we really focused on this being an iterative process, looking at how do we start and build solutions for different aspects of the provider market in order to bring folks towards a common vision. And so we focused on a couple of social domains. Again, phased consensus building was an important approach. We were supported in our ability to take this approach when we looked at screening for social needs. The existing HL7 Gravity project, which was putting out data standards for bridging together social need diagnoses, patient goals for social need interventions, and the social need interventions themselves, allowed us to basically say we're going to leverage these standards, leverage them to focus on what's the most effective and efficient way for us to support frontline staff who are addressing some of these social needs without needing to without needing to redo any sort of technology solutions, or doing that as little as possible. And so then, of course, this referral capability, looking at closed loop referrals, enabling notifications to a care team, and having that information be accessible through HIE. So those solutions, or those recommendations led us toward three options based on looking at the market. And that was really how we evaluated through those recommendations, these three key options. So we looked at buying either procurement of a solution or a license of an available product. We looked at building out existing infrastructure, assuming custom software development. And then we looked at sort of a bridging combination of those that really focused first on interoperability capabilities and starting where people are. And so we chose this bridging solution, building upon existing DCHIE capabilities, identifying and assessing gaps in current capabilities that could be addressed by third-party platforms, and again, focusing on existing workflows, existing community partnerships, and achieving buy-in through quick wins. And so, some of those existing solutions or quick win solutions involved, leveraging the solutions that other parties in the market had bought. In other cases, it looked like low-hanging fruit for building out something that could support organizations to participate. It really meant starting from, where are our providers right now? How do we meet them where they are, and how do we build on that based around the principles and priorities that we laid out? Okay, so one reason that we were able to choose this bridging option is that DC has already invested pretty substantially and effectively in expanding health information exchange. So this is like a snapshot of the coverage of health information exchange in the district. All hospitals, all federally qualified health centers are connected to HIE. Most of our long-term facilities, home health providers, behavioral health providers. We're now growing, starting in this year, a network of community-based organizations in the district and in Maryland that are connected to CRISP. So this is an overview of DC, but since I just said the word Maryland, I'll also mention CRISP DC is the District of Columbia's designated HIE. CRISP is also the HIE provider in Maryland, West Virginia, and I believe one or two other states. So they have long experience as a partner in this project, and I'll mention sort of how they fit in more concretely. But they are really the primary place where we're connecting solutions in the market using the existing HIE to really fulfill a new role, or at least move into a new domain in terms of moving not only healthcare information, but social information about patients and resources as well. And so to that end, you see just sort of, again, the snapshot of how many people are using CRISP, how many locations are using it for sharing information about discharge or transfer, clinical care documentation in general. So the HIE has these 6 core capabilities. The ones in red are the ones that are part of our CORI project. Importantly, what you're seeing in the first one, community resource inventory, I'm going to talk about that based on our partnership with Greg and open referral. That is primarily information about resources, so not necessarily patient protected or personal health information. but about making sure that we have reliable information about community resources that are out there. So it sits alongside that provider directory that is available through the Health Information Exchange. And then secondly, the larger red box here, screening and referral for social needs. So there's a couple of different solutions there, but specifically we're talking about sharing information about people, generally HIPAA covered information that requires certain levels of standards in the way that it's being used. So Corey, overall, we are a partnership of the Department of Healthcare Finance, again, that's DC Medicaid, CRISP DC. CRISP stands for Chesapeake Regional Information System for Patients, to give you a sense of what they're doing and where they are located. DC Primary Care Association, that's us. We represent the federally qualified health centers, and the DC Hospital Association collectively form this Corey partnership. DHCF is the funder and CRISP is the lead. We've committed to supporting technical solutions and enabling whole person care across health, human, and social service providers in the district. Those three technical functionalities that I just showed you, again, are showing up here: screening, lookup of resources, and referral. Together, they are the baseline functionalities that enable data sharing across health system stakeholders about social needs. This is the part, and this third part, and it goes back to our buy, bridge, build framework as well. Corey is a vendor agnostic approach. So we enable screening and referral information to be shared and displayed regardless of how it was collected. We are ensuring that care partners can view the same information via DC HIE regardless of the vendor platform they use. That extends to resource information as well. And so that interoperable system part, we're connecting care partners to the data utility who are not yet. We're making new functionalities available to system users, providing shared services across the region, and trying to foster a culture of shared responsibility for ensuring the availability and quality of actionable information. So, here you see what that looks like as a graphic. So we are designing to enable screening and referral. So again, this is just screening and referral that you're seeing here through the HIE infrastructure without requiring a single district-wide platform. So providers, MCOs, community-based organizations, other stakeholders can collect information about their patients' social needs and make referrals to community services. So they have one of four pathways that they can use. The first three deal with sharing information about patients. They can do that via a third-party social determinants of health network platform like Find Help or Mommy are the two in the district right now that have integration with CRISP, and other platforms have that option as well. You can capture social needs information directly in a medical record system in the EHR. Some of the ones in the district include eClinicalWorks, Epic, and Cerner. And that can happen in a number of different ways that information can be shared with CRISP. They're pretty flexible in how they receive that information. And then finally, users can actually use CRISP directly via their web portal to actually use the screening tool within CRISP. So if they're not already using a third-party platform, a medical record system, they could use CRISP to capture that information. And then all of that goes in the top right to a central location within the CRISP portal where they can see information about patients and their history. And then finally, the fourth thing is they have a referral tool within CRISP that can close the loop. And we're working on similar agreements with third-party platforms. We already have that ability to show referral history, for example. Could we begin to expand not only people making referrals within CRISP, but maybe in other systems as well, and facilitating that? That might be more of a future state, though. So to support all of that screening and referral, as I've mentioned a couple of times, CRI is a core component of that community resource inventory to enabling and supporting navigators in the healthcare system and social service system to know what's available. And we have funded already through Corey this aggregation of resource data from a range of existing databases and have put that out now into 3 different formats. District district residents or others who are looking for resources in the district can go to via web browser, our website for this, dc.openreferral.org, publicly accessible, being updated all the time. Secondly, they can actually receive via application programming interface, or API, which is a web tool for just retrieving in batch format information from our directory. So you can essentially view it in a human readable format at the first one, or a machine readable format in the second one. And then the third way that users can access this information is directly within the CRISP portal. So that allows us to display, right now, basically the same information, but within the sort of seamless, generally single sign-on or some sort of EMR app display that makes it simpler for folks who are working in a health or social service context to access that information. In the future, that also might allow us to display different sorts of information to folks who are just accessing it within the CRISP portal, for example. So then all of that is being supported through work that we've been doing through the DC HIE Policy Board, which is appointed by the mayor, represents, many of the same segments of the health care system that have just been mentioned, various public health agencies. They actually established a subcommittee, and this was the project that we worked on with support from DASH, to develop the standards related to use, exchange, sustainability, and governance of CRI data, with the goal of ensuring that that data is consistently reliable for CRISP users' ongoing maintenance. So that brings us back to the central problem that Greg described of, if this information is going to be published in all these different ways, how are we going to sustain it as infrastructure? So this graphic is bringing together the three different models that Greg laid out in his presentation. So you're seeing here steps 1 through 5 describes how community participation is required in order for us to maintain these open access portals for people to pull this information in. So in the first two columns on the left, 1 and 2, you're seeing community programs and service information from disparate sources are fed to various databases managed by regional data stewards. And those stewards are generally assuming some level of responsibility for the information from each of their sources in their domain. So in the district, we have some government agencies like the Department of Aging and Community Living or the Child and Family Services Agency that are maintaining internal databases or published databases about elder care or other services on their own. We consider them a steward and they have a register. And that's true for non-governmental agencies like the Capital Area Food Bank or us at DCPCA. We're also looking across state lines, working with Maryland 211. There's a lot of overlap in terms of services that people seek. So we're also seeking additional data steward partnerships there to bring more information into the database. In the middle, the third column, number 3, you're seeing the data collaborative or the data federation strategy that Greg described. So each individual steward can contribute information, retrieve information, and know that the information that is being kept in this database meets certain standards, is using our inclusion exclusion criteria, is using other standards that can be shaped by the stewards themselves to ensure that their participation is sustainable for them. And those standards and governance solutions are being really hammered out. We've been working on it for more than a year now through this CRI subcommittee. And I'll tell you a little bit about how that's shaping up. And then the final 2 columns here, 4 and 5, are the data utility strategy that Greg described. So we are performing quality assurance. I saw there was a question in the Q&A that just came in about that, because we know, that the information coming in from stewards still needs some quality checks in a central location, especially if we're sharing and receiving information from multiple stewards. That adds complexity. And so there's, quality assurance that we do internally. And finally, publish that information in the 3 ways that I just described: via the web, via the CRISP DC portal, or via API. And that API piece really is potentially a market-shaping institution in terms of enabling third-party providers to build on top of what they will hopefully consider to be a sustainable source of data for them. So we've shown this information to data stewards before, but there's really three roles that we see government agencies or other data stewards playing to participate in this CRI ecosystem. So we're working with government agencies and other stewards to establish a service register of their own services, keep that information and share it with us in a way that is interoperable. Where they are contracting with third-party vendors, we're looking for them to promote alignment through that contracting, through data sharing agreements and other solutions within the agreements that they sign to leverage those dollars and resources and investments to support the utility and have the utility in turn support those vendors and ultimately those agencies. And then we're able to deploy the data within the CRI for the needs of these different agencies so they can leverage the CRI as a source of information for their own websites. My Recovery DC, a list of substance use disorder resources. Link U DMV is a find help resource put out by the DC Health Department. Criminal Justice Coordinating Council resource locator, the network of care that is used by a number of government agencies. There's a lot of resource data efforts, and we're looking to have each agency examine, where best they can leverage what exists to meet their own needs, as well as contribute back to the utility. So I'll just close out here again, just to emphasize the policy board and our subcommittee. I'm actually the vice chair, and Lucy De Oliveira is the chair, although she kindly considers me to be a co-chair. Our mission, again, building the capacity to share, find, and use information about resources and developing recommendations. So we're going to have a HIE policy board meeting next month to look at how do we to look at the recommendations that have been developed. So I'm not able to share the full recommendations now, but essentially what we're looking at is more formally designating CRI entities that are participating, stewards, utility, et cetera, who can share data management responsibilities, exchange that data via established standards, and have that be something that ultimately the HIE and through the HIE, DHCF, DC Medicaid, and even the dollars that are available to support health technology infrastructure across the country, allowing the district to again pull down some of those resources to make this sustainable through Medicaid and health technology support. So we see this as sort of a prerequisite for DHCF to do the work that they're looking to do to establish the HIE as a long-term sustainable concern, supporting the market of healthcare and social service providers that are using this information to complete their missions. So I will close there and pass it back to Waldo to facilitate our Q&A.
Great, thank you, David, and thank you, Greg. We do have the Q&A section open, so if you haven't already submitted questions, feel free to do so at this time. I am going to go ahead and pose a question to both of you, and we have a lot of infrastructure in the DC example. A lot of the work that David and Greg did there, and David's collaborators. We have a lot of communities that probably would be interested, certainly, in the kind of policy response, very much like DC has done with CRISP and their state Medicaid agency. That isn't always the case everywhere, though, right? Again, the ecosystems vary community to community and state to state. So here's the question: someplace else that's not the DC ecosystem, that doesn't have maybe rather an HIE in it, or an HIE that's that you're collaborating with. Maybe there's a 211, maybe there's a CIE. The different kind of configuration of partners who would do this. David, I'm going to ask you from a governmental perspective, how, if we have folks in maybe state agencies who are looking at this type of solution, looking at this type of response and partnership, how, what do you look for? How do you start those conversations if you don't already have those collaborations in place? And Greg, I'll ask you the same question in the inverse. From the kind of resource directory side, from our more traditional partners who've worked with that, 211s or United Ways, who maybe are sponsoring collective impact type of collaborations, how do they get to their state partners? I'll let either of you answer first.
Yeah, we've been very lucky to have support from DC Medicaid and the HIE. Of course, we've also been, as a primary care association, working with community health centers for a long time, have been, leading various health equity efforts. So we were able to leverage our role in the community as, already a leading convener of folks working towards health equity solutions. To bring together our members, community-based organizations, and really in those first couple of slides when I was talking about the needs assessment and our action team, that was all geared towards identifying what would it take for us to have a system that would achieve these different outcomes that we're looking to accomplish. And so really tracking and identifying and just mapping out, here's what it would take for, each of these organizations who ostensibly, different plans would be relying upon to participate and perform various solutions. And a lot of times that meant, surfacing information that, was counter to various assumptions. Like a key assumption of a lot of these efforts has been, for example, we're going to refer people to a food pantry and they're going to serve them, and that's that. And the more people that you facilitate to go someplace without resources to support that place, you're sort of maintaining some of the market failure metric, in place. So we can't necessarily assume something as simple as, if a place is listed in a resource inventory, they're going to accept a closed loop referral and all of this, which is, it just something that has, I think, become more prominent in people's awareness, but was an early assumption that we had to upend in order to figure out how do we, design for a better system. And so I think doing that task, doing that upfront work of organizing providers and talking to patients and communities to understand how, we would accomplish some of these goals and what the implications of different changes to the infrastructure would mean or wouldn't, was necessary for us to really have leaders beyond our key partners listen and understand the need to invest in these solutions that are more equitable.
Great, thank you. Greg, the other end of the telescope.
Yeah, I mean, I think my answer might be pretty simple, Waldo, which is, first of all, I'm not a technologist, I'm not a policy person, I'm a community organizer. And one of the first principles of the kind of community organizing I do is that you assume that in any given community, given a problem that you're interested in, there's already people who are experiencing the pain of that problem and working to try to devise solutions. And rather than assume that they're not enlightened, that they've gotten it wrong and that you have to beat them at their own game, my work is assuming that actually they have insights that are valuable and maybe even essential. And so you should start by asking them what it is they want to be able to do better and listening. And you should proceed from there. So I do agree that DC, the scenario David's describing, I think is almost ideal, where you have a government that's like, we should be funding the production of infrastructure, we should be supporting stakeholders in the process of organizing themselves to be able to govern that infrastructure. It's terrific, I'm thrilled. A lot of places don't have that kind of government and don't have that kind of connective tissue. But rather than being like, oh, well, then we just can't do this kind of process, we should, hire a company. You should assume that there are still people there who are trying to find ways to, to solve these problems, and start by talking to them and repeat that process. And that process might lead you away from the idea that, you're going to throw in some sort of database or some software system and you'll solve these complex problems. And that's probably healthy. That's probably going to save you embarrassment or worse. By talking to the people who've been working on the problem for a long time and thinking about what it is that they need, you will probably avoid making a situation worse than it otherwise would be, even though you're well-intentioned.
Great, thank you. So kind of a follow-up to that question. Greg, particularly you talked about the kind of market forces and the market failure in some cases. The idea of kind of conversion there, where we could either support or influence the market in positive ways that would nurture or foster an ecosystem. Would either one of you have, from your perspectives, kind of ideas around what kind of incentives could help promote some of that? But and again, I'm going to ask you to stretch a little bit and maybe draw from what you learned in DC, but maybe that could be applied in other communities that maybe have are earlier on in their journey.
So the question is how to essentially promote and incentivize the process of shaping a market, right? Okay, so yeah, I like this question. Rather than being like, there's a problem and we have all these different people with competing ideas for how to solve the problem, and then you engage in essentially like a death match over, who will be the one, which doesn't go well for anybody other than maybe the shareholders of whichever one ends up on top. The question is, how do we actually make decisions together about the conditions in which we're all going to work, given that we all have some common goals, even if we have different specific objectives, given the particulars, right? And so then the question is how to create the context in which these different actors with incentives that could be aligned are going to actually do the work of that alignment. So I can answer you first from the question of like, when it comes to policy, from a governmental actors, like potential roles in this, just taking our particular domain, a government, first of all, provides services and can make sure that information about the services that it provides is available in a non-proprietary standardized format, right? So that the entire market is now incentivized to consume data about services from the government. That is a thing a government can do to sort of lead the way, incentivize cooperation by acting cooperatively and saying we are going to publish information about the services that we provide and maybe the services that we fund in this standardized format that everyone can use. The next thing government can do is actually like further incentivize cooperation through procurement policy, right? By saying, if you get funding from us to connect people to information about services and you collect that information with public funding, it has to be made available in a standardized non-proprietary format. It has to be accessible for others who are using other information systems. Government can build into its contracting processes through procurement, essentially requirements that, different actors in a marketplace are on some level behaving predictably and in the same way. And if you wanted to be really thorough, they can also promote monitoring and compliance processes through procurement, right? Like any given contract can be like, and you will specify how this will be monitored, or so on and so forth, right? And then the government can obviously also like fund the research and development that has to be done collaboratively as well, right? It can actually incentivize cooperation by funding cooperation. That can also more or less apply to foundations, right? And other authorities, right? That framework for thinking about the different layers that an authority institution can play to incentivize cooperation in a market. Like that's a top-down perspective. In terms of like, I think David mentioned collective impact. That I think is a useful reference point for thinking about like what's the shape or what's the context in which decisions could be made among many different stakeholders who have some common goals. And a lot of times collective impact, initiatives kind of flounder because they want to solve like huge problems, and like it's just like it's too complex, for it just becomes an endless series of meetings. But if you do have a very specific scope that is within the range of like what could a group of organizations influence, like that method of bringing everybody together, saying what are our common goals, what are our shared metrics, and then what are we going to do to each pursue that common goal together, like that's the work. Ultimately I think there are some assumptions that are sort of cultural that we do allow to influence our decision-making processes, assumptions that like, the best ideas will rise naturally to the top in a competitive marketplace, because like, how could they get money if they weren't really good ideas? And that assumption doesn't actually really hold out, because the people with the money are not necessarily the ones who know what needs to get done. And there's also an assumption that technology is magic. And, if you get the right design and the right database, you'll be able to solve all these complex problems. And it's very naive. But the work of just getting people together, having them talk to each other, having them listen to each other, documenting what was said, and then repeating that process, like that like it's not rocket science, and it does lead to better outcomes. Of course, it takes capacity. Like somebody's got to be able to organize that process. And usually our funding mechanisms don't really incentivize, don't really fund the actual work of coordination and collaboration. So that I think I do think it does go right back up to the funders, and in changing the way we allocate resources so that those resources are actually being allocated to the work of working together. And I'll pause there.
Yeah, that's a great collection, and what I appreciate is the inclusion of the collective impact as actually a kind of an incentive, but also a scaffold to build this work off of. David, you talked about the collective impact model kind of quickly amongst all the other things that you included in your presentation. Could you just spend a couple of minutes teasing that out a little bit for the folks on the call?
Yeah, sure. I think we like to reference collective impact and the accountable health community model, collective impact being the way that we've sort of evolved the accountable health community model, but still working towards this sort of common goal. And a key part of collective impact is, identifying shared agenda items and shared measurement goals that people can begin to work towards across disparate systems and locations. So reducing isolation and silos and fostering partnership and ultimately sort of coordinated impact towards a few distinct goals. It is a process. So a lot of what is out there on collective impact focuses on how you facilitate that sort of process. You don't necessarily know where you're going, or you have to sort of bring folks together to say, we've got lots of different ideas on how we solve this problem. How do we, prioritize amongst them? The collective impact model has these 5 key elements, this common agenda. I shared our problem statement, vision, and mission, as well as our strategic goals. Those are some of the key aspects of a common agenda. You have to first agree on what the problem is. And then you have to decide, what does it look like that when we fix this problem? And then you can get into these goals. And another key element of collective impact is some sort of backbone organization, or more effectively, probably like a network of champions of a particular project and mission and vision that are supporting the work towards the strategic goals. So the work could look like, working groups, ideally not meeting for more than 5 to 6 months, or 8 months, not an ongoing effort, but rather an attempt to answer some specific questions through investigation, through understanding of the situation, and better understanding of how each stakeholder represented in a working group might be able to live with and work with the recommendations of that group. So, sort of the continuous improvement, even verging into sort of move fast and break things, but in this case, move fast to understand, the situation, and then take care to design the solutions at a pace that fits for all parties. So our approach that I mentioned of literally iterative design solutions, we've begun to facilitate technology solutions that work for different parties to do different things. They're not all using the same system and have all the same tools available to them, but as long as everybody is seeing this support, being mutually reinforcing towards a collective goal, mutually reinforcing activities being, a third component or a fourth component of collective impact, you really then can, if you are using this last one of continuous communication, you are seeing everyone across a network have some advancement towards the goal, and you're iterating across the goal and building excitement with champions, and ultimately revealing the solutions along the way. So it's a process of evolution that lets us work on stuff that we don't know the answer to. I don't know how many grants let you do that, but it's a vital part of any sort of project that moves beyond programs and into system solutions. And that goes back to what Greg said, like very few opportunities for organizations to be facilitating networks that elevate solutions that are beyond just programs or populations. So we have to have that type of support for organizing to make that type of thing happen. And it's not a quick process. It's a slow burn in some ways, but you have to have that base of in this case multiple sectors, data across sectors, in order to make that happen.
Yeah, and it would seem that, within those shared measures or shared measurements, things like quality and standards, evaluation, even we have a couple questions on that came up about quality management and, how do you handle informed consent? And it seems like that process of the, kind of the evolution of those discussions takes that into account for every community. And if that's a priority and that's a shared measure that community, wants to invest in, then that's part of that process of development. We've exhausted the questions that we had in the chat, but any closing thoughts from either of you on important points that maybe we didn't
Well, I would just highlight, I was invited on to talk about resource directory data. Obviously, the dynamics of this kind of information are different from like data about people that might be shared among many different systems. Personally, I've appreciated the opportunity to be working on this information as opposed to like the challenges of like making a referral from one system to another, because it's just lower stakes, right? Like this is public information. We can experiment without putting people in, in harm's way, or, without the liability of, potentially some sort of HIPAA breach. So, so it was an easier opportunity to try new things when I first started this work, I was like, relieved to not have to deal with personal information being shared among different systems, because it seemed like that wasn't going to be going anywhere. That was a long time ago at this point. And now the market for solutions to, sharing people's information among many different organizations is really heated up. We now do have standards for that kind of thing that are potentially usable by many different groups. And, I think I'm tentatively optimistic about the potential for that work. But some of the same ideas that we've brought to bear in open referral and in the development of this resource directory data infrastructure, I think desperately need to be applied also in that field of personal information exchange, because I'm seeing a lot of the same confusion that hindered the resource directory information market. The idea that there could be one website that everybody uses, the idea that if we build it, they will come. Those ideas seem to be animating the market of solutions to the social care coordination problem. And they're not good ideas, right? They're not, those are facile notions that don't hold up to a moment's examination. And, if you want to make a good website, you have to make decisions about who that website is going to serve and what it's going to do, right? And inevitably, you're going to prioritize some people over others and some actions over others. And if you want everyone to use that website, then it's an inherently inequitable proposition to whoever you're not prioritizing in the design of that site. You cannot build a user-centered tool that serves everyone. And so my proposition to the field is, don't try. Build infrastructure that enables the flourishing of many different tools that are purpose-built to specific kinds of users with specific kinds of needs. And don't try to build the one website that will solve everybody's problem. That it doesn't sound like that is using essentially market logic, but the market logic of the 21st century, where we have 6 websites on the internet and everybody hates them all, right? We have to learn from the quote unquote platform era, which didn't really work out for us very well. And instead think back to what made the internet a generative and resilient force in the first place, which was standards and infrastructure and small things that work together effectively. And we have to be focusing our energy on what kind of markets do we want, rather than what software will we try to force everyone to use. And I'll pause there. How about that?
Great, thank you.
I will echo a piece of what Greg just said, which is, the policy environment really shapes the market environment in a lot of ways. And I think for us, we've had the space to do a lot of organizing, a lot of investigation, a lot of determining, what are our measures, and that shapes, years down the line, the policy that we're putting in place. The idea of fueling the market with infrastructure has, I think, been part of our vision from the beginning. And with our look at what already exists in the market in the district, we sort of had to make that choice. I mean, there was I referenced at the beginning of the questions, what's working for people on the ground. We have to start from there. We saw different things that weren't working already, and so we needed to incorporate that into a policy agenda. Oftentimes, it seems like initiatives like the kind that Greg warns against seem to be born out of efforts that have metrics other than, let's say, community health and wellness as their starting and endpoint, and so you might have something that is a tool that could be used, but how are the people that are, deploying it being judged on the success of that. So some of these platforms that have emerged in the district, emerged in other places, the goal is not necessarily, the people who are deploying them are not necessarily judged on and accountable to, certain improvements to, the provision of social need resources, right? So we have to be very careful in designing, whether it's hospital community benefit or value-based payment or managed care or other aspects of the system that impact this part. I think the insight of collective impact on shared measurement driving alignment, I think is really important. Like we have to determine at the outset of these things, or at least memorialize in policy. Okay, our goal is interoperability. Our goal is, really, interoperability is a tool toward, community health and wellness, and how will that work? So there's some consensus building that always has to happen in the policy space in order to then facilitate, what you're looking to achieve in that. And I think we have to look at health policy around social and clinical wellness as really a lot more together in how we are being held accountable for that as a system. So I would say, improving accountability through policy is probably the most important thing that we can be working on right now.
Great. Well, thank you, David Palms and Greg Bloom, for your time today and participating in this discussion. This is super informative and really supports a lot of what we heard, what we've learned through DASH thus far, and hopefully what we shared today helps people think about some of the issues and approaches that they could take in their own communities. We want to go ahead and close out today's webinar. If we get the slide deck back up to the last slide. Great, thank you. We'd like to thank everybody who joined us today on the webinar. And we're really going to ask, please, as you leave today, remember to take our post-webinar survey. This is what helps us know if we're providing you with what you want and what you need from our work. We will be releasing the DASH framework itself in October at the All-In National Meeting. And here's a quick plug. There's the information for how to register. The registration is still open for the All-In National Meeting, and you can visit the bit.ly on the screen or visit allindata.org to register. We thank you and ask everybody to have a wonderful day. Goodbye.